I think I know most of the people in the room at this point, but I'm Leah Brandt. I'm the co-director of the Center for Health Ethics, and I'm really excited to be able to introduce our next speaker. Our next speaker is Ruqaijah Yearby. She is a nationally recognized scholar, professor of law, and associate director of the Law Medicine Center at Case Western Reserve University School of Law. She has written numerous law review articles, book chapters, and an editorial which was reprinted in USA Today magazine. Using empirical data, her research explores the ways in which laws and policies implemented to eradicate racial disparities in health tend to exacerbate the problems by erecting significant barriers to accessing quality health care. Bridging the gap between numerous disciplines, her work has been used in legal and social science courses at NYU and UC Berkeley. She's been cited in the Oxford Handbook of Bioethics, Implicit Racial Bias Across the Law, the United States Code Annotated, and written testimony before the United States Senate Judiciary Subcommittee on Human Rights and the Law. Her latest work, Breaking the Cycle of Unequal Treatment with Healthcare Reform, Acknowledging and Addressing the Continuation of Racial Bias, is excerpted in Dolgan and Shepard, Bioethics in the Law, 3rd edition. It's also cited under the Law Review section in over 10 sections of Title 42 of the Code of Federal Regulation. Now, that was a mouthful. So very excited to invite our next speaker to the podium. Please join me in welcoming her.
Thank you for inviting me, because oftentimes I give talks at law schools about the legality of the ACA of racial bias. But my work is moving more towards how can we actually address the problem with the people who are seeing patients. How can we come together to fix this problem? And so my focus is not going to be on patients, because a lot of the laws have focused on patient education. I love the last presenter who talked about we expect patients to understand when they need to go to the hospital and understand everything about their care. And so what I focus more on is how we within the healthcare system can make it better and improve it for everyone. So I often start with this page, just talking about injustice in healthcare. And what I mean about injustice focuses on everybody, covers everybody in this room, actually. When we think about justice in the healthcare system, our healthcare system is not working for anyone. Whether you be a white male, whether you be black, gay, whatever. And so I'm going to spend some time just briefly talking about justice and the lack thereof in our healthcare system, talk about some of the history, and then I'm going to move on to why do I focus on racial bias in healthcare particularly. So I saw yesterday you had a speaker that talked about justice in healthcare. I'm going to do it a little differently. When we talk about the healthcare system, equality, and treating everyone equally, when you look back at the history of our healthcare system, it was never set up to do any of that. Justice, equality are not one of the tenets of our healthcare system. It is for the people working within it, but that's not how we actually organize it. When you go back to the history of our healthcare system, right after the Civil War, when we were voting on whether we were going to have universal health care that covered everybody in our nation, one of the leading causes why we don't have it and why there was a creation of Blue Cross and Blue Shield is because we wanted to keep people separate. And that has been a continuing theme throughout our healthcare system. We wanted to keep the races, the sexes, and the classes separate. And so even though we passed several laws, including Title VI of the Civil Rights Act of 1964, and that's the Title 42 that my article is cited in, which I'm excited about, that says that everyone should have equal access to health care no matter your race, ethnicity, sex, that even though we have those laws on the books, without the value added to our system, you actually do not have change. And so when I talk about health disparities, I focus on all of this. Unfortunately, the thing that we track the most in terms of disparities are between the races, between African Americans and whites. And that's the highest disparity in healthcare in the United States, and it's the thing we track. And so it's the thing that I discuss, but I will often talk about some of the other issues related to health disparities. So I'm going to give you a health disparities definition, but briefly before I go to this health disparities definition, research has shown that 83,570 African Americans die annually each year because of lack of access, equal access to health care. I'm going to talk about some of the social determinants of health, which are often discussed in terms of bias within our healthcare system and inequality, but I'm going to go further and actually talk about stereotyping, prejudice, and bias, and the racial bias in healthcare. And as I said, because we do such a wonderful job tracking racial bias in healthcare, know that when I'm speaking about this, I also believe this covers class, gender, and other issues. I'm going to discuss some of the solutions that are provided for in the Affordable Care Act. And then I'm going to move on to my particular solutions, because I think that we can always do better, that the ACA may be a good start, but we have a duty to do more. So let's talk about health disparities definitions. How many people have seen this definition that I have up here? Not that many. Okay, so it is a fabulous definition from Healthy People 2020. What people tend to do when they look at this definition is believe that it only covers certain groups of people, right? Because we do research on racial bias, we do research maybe on socioeconomic status, that it only focuses on that. But I can tell you that everyone in the United States is covered under this, because when you look at our health outcomes, yes, African Americans are at the level of some developing countries, but the rest of the nation put all together is on a level behind every other industrialized nation. So we are all covered under this health disparities definition. All of our health care is poor, and research has shown in part this is because of the lack of inclusion of this value of equality, that we should treat people because they need it and not based on whether they can actually pay. Now, I do want to stop for a minute and talk about, in particular, this issue about race and ethnic groups. Most definitions of health disparities allude to race in a biological sense. As a former, well, not former, as a biology major, I graduated with a BS in honors biology, who focused on evolution and genetics. I have some history and background in biology. Race is not a biological category, and let's talk about that particularly in the research so that you know as I move forward when I talk about racial disparities in healthcare, I'm really talking about inequality that leads to these problems. So some may argue that biological differences between racial groups are the causes of racial disparities. In fact, I think a person just came out with a book recently about this. However, it's proven by the Human Genome Project and noted by Professor Nancy Krieger, the biological race theory is based on three flawed assumptions: that race is a very biological category, that the genes which determine race are linked in the genes that affect health, and the health of any community is mainly the consequence of the genetic constitution of individuals of which it is composed. And why I highlight this is because sometimes I think in the health field we get lots of information about racial disparities and we don't know how to address it. Do we need to partition people? Is it helpful? And so for the rest of my talk, I'm going to talk about why we need to really let go of the race unless we're talking about bias. And let me just give you an example. My son, who looks like me, went to the doctor. He's been to the same doctor for the last, let's say, 3 years. All of a sudden, they instituted this medical record, which they give you after they see you, which I love because it allows me to look at what we've done. On it, you know what race he was marked? He was white. That's all I have to say, right? And so you can check a box. I can go in there and check a box, white, black, and that's how we're tracking this biological category. I recently purchased a house. I talked to the loan officer on the phone when I got the loan documents. I was Asian. That's about how much I think there is a link. Now, we can talk about it later, but I just wanted to highlight some of those issues. And when I do talk to med students, we actually go through some pictures of people, and I have them try to pick out their race, and it's not that easy. So if you would like to talk about that more, let me know. All right, so let's talk about racial disparities in healthcare. And if we did a good job tracking class disparities, I think you would see the same thing, including in gender disparities. You see difference in disparities. And this is from the Institute of Medicine report from 2003, the unequal treatment report. Now, where I tend to focus on particularly is this area, discrimination, bias, stereotyping, and uncertainty. And that's what the Institute of Medicine focused on in terms of the differences in care between patients and healthcare providers. This came out over 11 years ago, but unfortunately, when you see lots of the reports, when you look at the Affordable Care Act, this is the one thing that we really do not talk about in any of those, and that's what I focus on, the failure to carry it forward and to actually address some of these issues. All right, so let's talk about social determinants of health. And when we talk about racial bias in healthcare, these are the things that are often raised, that it's something outside of the healthcare system that is causing and affecting people's health differences in health. And I agree with that, but it's also things within the healthcare system that is affecting their health. But let's talk about some of the differences. Let me give you some stats. In 2009, a survey revealed that the median wealth of Caucasian families was $113,149. What do you think the median income was for African Americans? Anybody want to hazard a guess? What would you say?
I just threw out 30,000.
30,000. Anybody else? Want to guess? 20? Lower. 12? Lower. Anybody else want to hazard a guess? 9? Lower. So actually, the median wealth was $5,677 for African Americans. Okay? And when you go into it further, let me quickly pull it up. They did, and this was a research study done at Brandeis. What they found that they traced the same households over 25 years. The total gap, the wealth gap between Caucasian and African American families nearly tripled, increasing from $85,000 in 1984 to $236,500 in 2009. And so clearly this is a problem when we're talking about health care, right? We're almost tripling the gap. That means you don't have access to transportation to get to your appointments. You don't have money to pay for your drugs, not adherence. Let's talk about another study. So a 2013 study concerning lung cancer deaths found that residential segregation increased the risk of death of African Americans. The more segregated the county, the more likely that African Americans in that county suffering from lung cancer would die. In 2011, a study estimated that 875,000 deaths in 2000 could be attributed to a cluster of social factors bound up with poverty and income equality. And that's why I talk about, as we look at social determinants of health, it goes beyond race, but we do a fabulous job tracking race, that it also includes poverty. Now, why is this a part of this issue about racial bias? Well, when we look at these issues of socioeconomic opportunities, housing opportunities, educational opportunities, they are linked up to racial bias. And so I'm hoping that all of you have heard about the recent issue with Google and some of the tech companies in terms of who they actually hire. There are not a lot of women, there are not a lot of minorities, African Americans, Hispanics, and that goes into socioeconomic opportunities. There have also been loads of studies and lots of disciplines, I think law as well, where they've done testers. They sent out resumes, they just changed the names, and they got different outcomes. The more African, a name sounded. So Malik, the less opportunities they had, even though it was the same resume as Bob had. Okay, and so that's what we talk about social determinants of health, is that you lessen the socioeconomic opportunities that affects your health. Unfortunately, this racial bias is within the healthcare system as well, and it affects African Americans' health status as well as their access to health. So let's talk about that. Oftentimes we talk about stereotyping, prejudice, and bias. And I'm just going to give you some examples of it in the healthcare system so you can actually begin to understand how it applies in healthcare and how it affects people's healthcare. So a stereotype would be all blacks eat soul food. And I remember giving this talk to incoming health students, and I had them actually go through questions about me. Now, I know the answer, of course, was, well, how do we know? You shouldn't know what I eat by looking at me. You shouldn't know what I did in college. You shouldn't know. But part of it was trying to get to their bias. And so I asked them what was my favorite food. A lot of them guessed soul food, a lot of them guessed some other things, but that's a stereotyping. Not all black people like soul food, and really, what is soul food? I've lived in the South. Lots of people eat soul food. Lots of people eat chicken. That's why lots of people go to Popeyes, right? That's not just a cultural thing. Lots of people eat chicken. Lots of people eat fried chicken. I do not. So therefore, that's a stereotype that I'm not actually in. Let's go to prejudice. So all blacks eat soul food. A prejudice: when treating a black woman for high blood pressure, you assume that her health problems are caused by eating soul food. Of course, I'm using really simple examples here, right? We're going to get more in depth, but just trying to show you how this bias can actually translate. All right, so that's the prejudice. The bias is you don't ask what she eats or in other important questions that can identify the real issue, which may be stress, right? And so we take these stereotypes, these prejudices, and then we use them in our treatment decisions. So let's talk about it. Who is biased? Everyone. You, me, everyone is biased. We walk around with our biases. If you watch TV, you have these biases. My 7-year-old has these biases that I tried to undercut. So we may say we love everyone, we're colorblind. We are not, okay? So if we acknowledge it, that's great so that we can move forward. Let me give you an example. Reverend Jesse Jackson was interviewed about walking down the street in Chicago. He was walking down the street, he heard a noise behind him, he started moving faster, it was dark, he turned around and saw the person following him was a white male, he felt better. And then he realized he actually had the bias, right? Because he said, oh, he's white, oh, I'm safe. Okay? And I use that story to identify, again, we all have these biases. So we need to check ourselves. And if you are interested in checking out your bias, you can take the test in the implicit Harvard study. I've known everybody who's taken the study has found that they are implicitly biased. Black, white, Latino. The only person who came out with a better score was actually an African-American woman, but she had taken it a few times. So I don't know if those are actual results, but I highlight that so that when we talk about bias, that we don't sort of close the door to saying, oh, I'm pointing at particular people. I'm pointing at myself too. Okay, so let's talk about racial bias in healthcare. There are actually 3 different types of racial bias. I'm just going to focus on interpersonal racial bias. There's also institution, what our institutions are set up, how they're set up. Why do we only provide care at a certain time? Most people who work cannot come to that. Institutional bias, structural bias, and that goes in a lot more to the justice issue of why is our healthcare system set up to provide care to the people who can pay for it? That doesn't seem to be an efficient, effective system, and so that's what I mean about structural bias. We should actually be providing care based on people who need it, the most. But I'm going to focus on interpersonal racial bias. And so it can be conscious and or unconscious. And when I talked about the implicit bias, that's the unconscious bias. But stay with me, because unconscious bias can be changed. Just because it's unconscious does not mean that it cannot be changed. And usually you see it in the physician-patient relationship. So let me talk a little bit about how it can be changed, and then I'm going to talk about studies that have shown us that it's actually there. It affects access to health care and the treatment that is given to African Americans. So since 2001, psychology research studies have shown that you can actually change a person's implicit racial bias. Some retraining that they've done is to show pictures of famous, well-liked African Americans associated with good things. So that would be showing them pictures of the Reverend Dr. Martin Luther King Jr., along with pictures of infamous Caucasians, such as Charles Manson, right? To go ahead and break this implicit bias that white is always good, black is always bad, and instead take the person as you see them. All right, so let's talk about interpersonal racial bias within the healthcare system. So there have been lots of studies. There have been studies after this, which I can talk about a little later. But we start with the first study in 1999, the Shulman study. And in that study, it investigated primary care physicians' perceptions of patients and found that patients' race and sex, gender, affected the physician's decision to recommend medically appropriate cardiac catheterization. Specifically, African Americans were less likely to be referred for cardiac catheterization than Caucasians, while African American women were significantly less likely to be referred to treatment compared to Caucasian males, right? And so there you have not only race, but gender in there. I'm sure as women in the audience, I know I can say that oftentimes when I go to my physician or a healthcare provider, it's a longer discussion about why I'm here. Yes, I have pain. Can you listen to me? Yes, 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 yes. And it even happens when I go to care with my son. A physician actually wanted to prescribe him an inhaler. And I said, well, do we need to really do that? I mean, he's just sick, he has a cough, this is the first time, and he asked me, well, what is the problem? And I told him, well, I just recently saw this study, longitudinal study had been done 10 years, published, and he just tuned me out. Now, that just could be, right, me, and the fact that I was citing to a study from JAMA, but I expected him to listen to me about my worries about giving my son an inhaler. And so I just give you that just as an example of some issues about bias. What was it that he didn't listen to me about? Was it the fact that he didn't want to hear about a study? He didn't know about a study? What really was it when he wasn't listening to me? When we talk, let's talk about the 2000 and 2006 Van Ryan and Burke study. And Dr. Van Ryan is one of the leading researchers on implicit racial bias. What they found in both of the studies is that physicians rated African American patients as less intelligent, less educated, and more likely to fail to comply with physicians' medical advice, even when they presented like this. They also found that physicians believed they were more likely to be drug addicts. So say I'm coming in to you dressed like this, which I'm usually not going to do because I'm not feeling well. I'm not going to put this on to ask you to treat me correctly, right? But what they found is that as a result of that, physicians were less likely to give medically necessary coronary bypass surgery. In 2002, 2006, they did surveys which showed that African American patients, when compared to Caucasian patients, were less likely to receive encouragement to participate in medical treatment decisions and less likely to receive sufficient information from their physicians about their medical condition. So again, that goes back to my issue in my son's care. All right. So when we talk about implicit racial bias, it covers conscious and unconscious. Aversive racism is when we believe that we have no bias, but we actually do. Right? So we believe we treat everybody the same, but we harbor this unconscious bias. And patients react to that, okay? What they found in this study in 2008 is that physicians of all races, all genders, were aversive racist. Okay, which means that when we begin to talk about solutions and we say increasing the diversity of physicians, which I am all for, we have to be careful because everyone carries this bias. And data shows that African Americans reacted most negatively to healthcare providers that were aversive racists. So believing that, yes, I want to help you, but acting differently, okay? And we can talk about what that means later, that they actually prefer people who were quite clear that they didn't like people of different races and acted it out because they felt that they were more truthful than those who were aversive racists. Empirical data shows that African Americans' perception of aversive racists and racial prejudice within the healthcare delivery system results in African Americans' non-adherence to treatment regimes, delays in seeking care, and interruption in the continuity of care, and reduced health status. And so why I focus on this, because we often talk about patients not adhering, but we don't ask why you don't go into the physician. As I can say, I've had various incidents where I've gone in and said, hey, to a physician, I broke my finger. No, you didn't. Oh, I'm pretty sure I broke my finger. Pretty sure. Well, let's go get it looked at. Got it looked at, came back. Guess what? You broke your finger. Really? Okay, so am I likely to go back to that doctor? Probably not. I did because I was an undergrad. I had no choice. But on my own, right, this question, am I going to go back? No. If you tell me something that is not what I think is the best thing, like my son with the inhaler, you can write the script. I'm not going to use it because you haven't listened to me. We haven't talked about why I actually need to do it. You haven't even talked about the side effects to it. So I can be a great example of when I feel people aren't listening to me, then I'm not going to do what you tell me to do, right? We are all like that. If somebody isn't listening to you like your boss, are you going to do what they say? Maybe, maybe not, okay? So think about that when we talk about these issues. All right, so how does that actually lead to poor care? I began talking about it because in some instances, if you don't believe people are intelligent, you don't believe they're going to adhere, they don't adhere because they don't believe you think they're intelligent, then they don't get the care. But these studies have really tracked this difference in care. In 1996, a study showed that physicians treated African American patients less aggressively than Caucasians. And these were Medicare patients, which is nice because then you can control and say, well, it's not a difference in their socioeconomic background. It's not a difference in what the healthcare provider is getting paid, that it has to be something else there. In 1998, a study found that African Americans were less likely than Caucasians to receive curative surgery for early stage lung cancer, which is linked to increased mortality rates of African Americans. And what they found, if African Americans patients underwent surgery at a rate equal to Caucasians, their survival rate would approach that of Caucasian patients. And this is why I began with the discussion of let's take the biological out of it and begin to discuss what is actually happening within the healthcare system, and are there ways that we can effectuate change. In 1998, a study found that African American Medicare patients received poorer basic care than Caucasians who were treated for the same illness. The study found that only 32% of African American pneumonia patients with Medicare were given antibiotics within 6 hours of admission, compared to 53% of other pneumonia patients. And that if they, and the studies have associated prompt administration of antibiotics with lower death rates. Finally, a 2010 diabetes study showed that when receiving care in hospitals, African American Medicare beneficiaries with diabetes receive less than the medically necessary treatment compared to Caucasians. And before I move on, I want to talk about a more recent study which actually goes somewhat into interpersonal, but goes to institutional as well. Often when we look at these studies, people ask me, well, isn't it about the fact that African Americans don't live in the neighborhoods where the best treatment centers are? Right? Is there that issue that they're not getting the best treatment because they're not going to the best hospitals? And that's not the case. A study actually showed that African American patients tend to live closer than Caucasian patients to high quality hospitals. The problem is they don't get into those hospitals. They get shipped to poor quality hospitals when it comes to curative surgery for lung disease and other things. And one of the issues is about referrals. The first speaker actually talked about the fact that it's all about relationships, right? How can you get in to see a particular specialist? How can you get in to get the best care? It's about relationships. And if your physician is not referring you, if your physician doesn't have a relationship, you can't get there. And so that's also an issue with interpersonal racism. So let's talk about some of the solutions. And these are all from affordable care. And why I've highlighted it, because I think that they're a great opportunity for us to begin to effectuate some change. But before I go into it, let me say that the Affordable Care Act was a step forward, but not a change in our value system about health care. It was a step forward because now we have more people covered, right? Now we have certain requirements that charity hospitals that see people have without insurance have to charge the same as those with insurance. But it wasn't a change to say that all people have a right to health care. I think the speaker yesterday talked about this in terms of justice. We don't have a right to health care. We don't have, even for the people working in health care, don't even have a right. And some of the people who work in health care don't have health care, right? And so as I'm talking about this, I'm aware that we still have a broken system. So I'll talk a little bit how to fix the system more, but I did want to highlight some of the good things about the Affordable Care Act. And one of them is healthcare provider education. So I know the speaker asked this question, but I'm going to ask it a little differently. How many of you have taken some cultural competency course in your lifetime? Okay, lots of people, and that is great. That's fabulous. I don't like cultural competency, though, because I think what it tends to do is to separate people even more, right? We learn about the differences of people. We have a different culture, so you might want to ask about that. What I think we need to actually do, though, is to begin to treat the person as a person. When you look at me, as I said, I don't eat soul food. So if you come in and say, hey, do you like to eat this? I'm going to say no. And that's not going to build our relationship. The key is to figure out more about the person and treat the person as such. So I talk about that, but I also think that in cultural competency, we, again, build in this implicit bias, right? That all black people like this, all Latinos like this, all women do this, you need to talk to this person. That's an implicit bias, that's a stereotype. And so I'll talk more about how I would like to change our cultural competency to be more about culturally focused, not culturally, but patient focused, right? Competency about the patient and not about the culture that they may or may not ascribe to. And so I think that is handled best when we talk about personalized medicine. There's been a lot of talk about personalized pharmaceuticals, personalized medicine, and that's really what I would like to get to in the sense that when a person comes in, right, if we have their medical records, we treat them as that person. Right? Each person is different. Maybe a law professor who walks in is not going to be the person who reads Medscape and JAMA like I do. But if you know me, then when we come and begin this discussion, then we can have a discussion at a different level than perhaps another law professor, another African American, another woman. right? And so when I go to you and say, oh, my son needs this vaccine, and you say, well, I'll check. And I say, you probably don't have it because the lab was shut down that was sending it out. Yes, I know way too much. But that we can have this discussion about it, right? And what we're going to do instead of spending time arguing about it, okay? And that when we talk about personal prevention plans, I think the first speaker was fabulous in talking about it, right? That we treat the whole person and begin to work on prevention and not just putting a Band-Aid on people's care. Finally, shared decision making. There's a section in the Affordable Care Act that talks about actually including the patient in some of the shared decision in their healthcare decisions, right? Not giving up any of your power, your knowledge about the healthcare system, about the treatments, but actually making people a part of their health. How wonderful you feel when you have been empowered to say, I'm making a decision along with my healthcare provider, and I'm actually going to follow that decision because I was a part of making it. I've tried that with my son. It doesn't always work, but it may for patients. Okay? And so my solutions, as I talked about in healthcare provider education, to change it, right? To actually talk about how we can treat the patient as a person, but at the same time that we're doing that, to also educate ourselves about the racial bias that we have and that our patients may have, and bring within our interaction. And so as I mentioned before, there's lots of information out there about retraining, retooling people about their implicit bias. And so what I suggest is that a part of this healthcare provider education, that we discuss how we all hold implicit bias, that how it affects treatment recommendations, how it's within the healthcare system, and affects how your patient reacts to the things that you say, and to re-educate ourselves about this bias so that we can lower it or at least begin to talk about it. Personalized prevention plan, health equity. This is another thing that has come about since the passage of the ACA, where it's really this plan to treat everyone equally. And let me give you some of the language. That health equity, making it clear that everyone deserves to be treated equally and deserves to reach their highest level of health. Just imagine what it would be if our healthcare system was based on that premise and that premise alone. How much better all of us would be, not only the people in the system and the people outside the system, but all of our health. And so what they have done is increase the diversity of healthcare providers, so that's one of their main goals, to ensure that healthcare provider training, and this is one of my suggestions, that treats minorities, so diversify healthcare providers, increase the number of minorities, women, African Americans, other people who have been without the healthcare system. But as you bring them in, part of the problem right now is that they don't have the same board certification, they don't have the same relationships. So you can increase the number of diversity within the healthcare system, but they have to have the same amount of power as everybody else, so when their patients need to see specialists, that they can pick up the phone and actually get that patient into specialists. I also believe in terms of health equity that it should include personalized plans, right? Again, this focus that everyone should be treated equally. I'm treating you and not just what I believe your population needs. And finally, in shared decision making, that there be patient treatment plans that encompass not only physician, nurse, that all the healthcare providers are included, but the patient is included as well. I think it's important to begin to ask, if you write a script to a patient, to ask questions about, can you afford this? Is this something that you're going to do? There are certain side effects. You may not know it, but to discuss it, to begin to discuss this issue so that we're all on the same page. So, in conclusion, I don't read from slides. I was taught you shouldn't, but I think this is important. Our urgent responsibility is to assure adequate health care to all Americans. I think that none would deny that consideration of race or color has no place with regard to the ailing body or the healing hand. 50 years later, we still have not accomplished that, not only for African Americans, but for the poor, for the mentally ill, for the disabled, for women, for everyone. If we could just achieve this goal, I think our healthcare system would be better. But in terms of racial bias, I think the time has come to end racial bias in healthcare, all bias, acknowledging our bias, forgiving ourselves for having this bias, and consciously correcting our bias. Furthermore, we need to rid ourselves of the belief that people, and thus patients, can be stereotyped based on race, based on gender, based on socioeconomic status, based on education, and really focus on their disease and the treatment and how best to help this person. We need to treat all patients as human beings who deserve the right to equal access to quality health care, regardless of whatever biases we hold. If we do not, I just aggregated the numbers since 1964, if 83,750 African Americans have died annually each year since 1964. That would be upwards of about 2.5 million African Americans who have died unnecessarily. And if we grouped all the women, all the poor in together, I'm sure it would be a much higher number. This is something we can address, and I think with all these people in here motivated to make changes that we can. Thank you. I'm ready for any questions.
Hi, can you address the issue not just of racial bias among healthcare providers, but racial bias among patients? Occasionally, one hears stories of patients who request not to be treated by specific nurses or physicians because of race.
Right, and so that's why I said I'm just focusing on one part, but I think it is a broader context, right? More needs to be talked about the implicit or explicit racial bias that goes on within the healthcare. It's no system, it's no different, right? And so it's patients coming in and saying, I don't want to be treated by this particular person because of race, which arguably is against the law and should not continue on. I know other people argue, well, they might get better health care if they're more able to speak with people and feel more comfortable. But I think part of the issue is that we want to overcome this. And how do we overcome this? So one solution is, well, you have that nurse and somebody else, okay, working together so they can provide the best care. But I also think one thing, and I know you didn't ask, but I wanted to highlight this too, is that we don't think about how racial bias affects the patient when they come in, right? That some of these health issues are actually affected by racial bias too. And so that's one issue I want to look at. But I don't think that people should be allowed to move forward on their racial bias. I can't. And I don't think that we should allow it within the healthcare system. If everybody's going to be treated equally, then everybody should be treated equally. I think there was a hand back there. Nope.
On the aversion racism, so white physicians have this aversion when it comes to treating African Americans. Is it the same way an African American physician would have this aversion when it comes to treating a white patient?
No, so let me speak about that. So that aversive racism is all physicians, some physicians of all races have an aversion to treating African American patients, whether you're a black physician treating a black patient, whether you're a white physician treating a black patient. So it covers it. And what it is this bias that we have that Caucasians are better, are smarter, are more educated. And so you actually see that across the races and physicians. So that you don't get that anti sort of Caucasian bias from an African American physician. That's not the issue. It's the anti-African American bias by African American physicians, Caucasian physicians, Indians more so. And as I said, Dr. Van Ryan is one of the experts in this area. What she found is that actually African American medical students, their implicit bias against African Americans increases the longer that they're in medical school. So when they start, they may have a low bias against African Americans, but by the time they get out, it increases. And so that's some of the issues that I have about cultural competency, that are we doing more harm than good sometimes.
So is that something that can be addressed within the medical classes that they're taking?
I think so. I think so. Right now we have some cultural competency classes, and so I talk about sort of shifting this paradigm and sort of saying not cultural competency, but what am I doing that is actually a problem? What am I doing that I could be better at with patients? And, you know, one thing I know I'm sort of in a different group is that I don't think that we should be teaching race in medicine, in the sense of if a person presents, why is their race important? Because I think it's problematic, because what tends to happen is sometimes if we always say African Americans have a higher rate of dying from breast cancer, then when a woman comes in and she's African American, then I've had stories of friends say, well, then the doctor told me you have breast cancer, you're going to die. That's not helpful, right? What's helpful is I'm a person, I have breast cancer, what are the things that I need to do? We may add on things, right? But let's not just start there. Let's start, I'm just a person, treat me, and then let's add on things. And so I think that could be helpful too, because when we put in race, you don't know how to handle that, right? I can't make you white, but what am I trying to do, right? And I think that's the key. Yes?
So to your point about personalized healthcare, and I understand that, and but knowing that certain groups are going to be at higher risk, so African American females typically present with later stages of breast cancer, or Eastern European descendants may be at risk for something. So to some extent, you have to consider some of it, I think. And I guess I'm just, I've taken my fair share of cultural competency classes through my career. But I guess I'm trying to figure out, how do you take that personalized medicine, personalized to the person sitting in front of you, taking into account, okay, just, we know, studies have shown that you're an African American female, and so I need to be more aware of that and keep the bias out of it.
And so what I suggest is that sometimes we use race as a proxy, right?
We couldn't hear the question.
Oh, she couldn't. So she asked, how do you take the race out? Because sometimes race comes into effect when you're treating a patient, right? In terms of the data that we have about disparities, about do people actually live longer, right? Particularly in terms of breast cancer. I'm going to use that example. And so what I love about your question is that you kind of answered what I think, right? In the sense of, we know that African American women have later stage breast cancer. Why is that, right? And so what I'm saying is that in terms of healthcare, we need to treat the problem, not sort of the proxy. So for African American women, part of the issue is they don't find out about it in early stages. They don't get the treatment they need. That's the thing I'm asking about treating, right? And not the fact that I'm black, right? And so the African American is sort of this proxy for, did I get seen? Did you actually test me? Did you do certain steps? And so that's what I'm saying we need to address as individuals, right? So if we know people are getting later care, then instead of saying, well, you're black, let's come up with a pill for it, why don't we actually improve the care? And so we increase the number of preventative measures that we have for that community so that they don't come in as late, so that they actually have better treatment, right? So that's what I'm talking about. I can't treat, as I said to the medical students, I can't change the fact that I'm Black, but I can change the fact that you can get me in and get me the care I need at the time that I need it. And I'll tell you, there's a wonderful book Dorothy Roberts just wrote about race and biotechnology and genetics. And she was tracking sort of this increased rate of African Americans in Chicago, African American women in Chicago with breast cancer. And up into 1980, whites and Black women had the same survival rates. And then all of a sudden it changed. Now I know, studying genetics, nothing happened, right? There wasn't a meteor, there wasn't something that caused a genetic change. We don't think about that in just 30 years. And so that's what I'm saying, right? In terms of individualized care, figure out what's happening with the patient. Right, new data is coming out all the time. Obesity is linked to breast cancer. Is that it? So do I need to get you to work out? Do I need to get you to eat better, right? Alcohol now causes cancer. So are those the things that are happening that we can change?
And are you aware of any racial bias where you're talking about the way we need to change? Because obviously in the classroom, it's an important place to start. But for all the doctors that are in practice and already doing this, are you aware of curriculums or a resource? Somebody's waving, sorry.
I think somebody is waving their hand. Did you want to go to that? I do have some. Well, hold on one second. So I do have, yes, I know that the Office of Civil Rights is working with the medical school curriculum on that, but I also suggest that as part of continuing medical education that people are taught about this. Not only about implicit bias, but how do you translate that data into treatment? Because we don't do a good job of talking about that. We just say, hey, did you know Black women die more for breast cancer? Go figure that out. So that's what I suggest. But over here, you were going to say something.
We're starting at the School of Medicine. We're starting at the School of Medicine, and also Columbia Public Schools has been doing this, working on doing inclusion training, which moves beyond cultural competency, uses a social justice framework that not only forces you to look at your own biases and privileges, or if you're on the targeted side, look at how you've internalized that oppression, but also lets you look at the structural issues that are creating and maintaining and perpetuating those biases in our society and within our institutions and organizations and cultures. And this, I think, then moves beyond cultural competency because you're trying to treat people as human beings, but also look at these systems that are removing humanity from our healthcare system. And that is started by, I was going to say, it started by the National Coalition of Community Justice out of St. Louis. Has a great program that they do, Inclusion Institutes, 3-day programs, and then they do a much longer kind of facilitator program that I took, as well as several people here, and I think about 20 or 30 have taken it across the Columbia Public Schools. So we're starting to get this education early and consistent throughout so that people are really starting to recognize these biases way before we even get them to medical school.
And I would just add that we've had, I think it's 65 people now from the University of Missouri Health System go through the 2.5-day Inclusion Institute at the National Conference for Community Justice in St. Louis, which is a 2.5-day immersion experience. It takes you way, way, way back to your childhood, to things you've heard. It really gets at all these inclusion issues. So if you guys are interested, we're trying to bring that framework to Columbia and make it more accessible to more people. Because a lot of people can't take 2.5 days out of their life, you know, but we're trying to break it into pieces and work with NCCJ to bring more of that activity to Columbia.
Yes?
What role do you think the mainstream entertainment media plays in perpetuating stereotypes?
Oh, I think that it all feeds into each other, right? It's the magazines that we buy, it's the things that we look at, and they keep putting it out. I just gave a talk Thursday at a conference in California where a woman was talking about this. And I'm going to step back from race, but she was talking about the images we have of women's bodies. Why do we always talk about women's bodies, but you never really see men's bodies, right? You don't see men in terms of the right to die. Quinlan, Shivo, all these are women, right? When we talk about the information we have, it's all women. You can trace that back to race too. Who do we see? So I've taken a little bit of training in college just about the images you see, right? When you hear about bad things that happen and they don't put up the picture, I was taught 9 times out of 10 the person is white. If they put up the picture, it's usually a black person, right? And so that begins to feed into this question, right? Not to touch on a touchy subject in Missouri, but do you want to discuss Ferguson in this way, right? Why do we need to know about some things about him? Why is that important if it's not happening there, right? Why every time something happens with the police outside in Chicago, they had a video of a police officer jumping over the bar and beating a woman? And there was no reason for it. But then we begin to learn, oh, well, this happened, she was in jail. Why do we need to know that? That did not affect him when he jumped over the bar and beat her, right? And so it's these things. And that's why I start off with values, right? If we're going to treat everybody equally, if that's our basic value, then it begins to color what we see, what we say, and how we act. And I'm not saying I'm perfect. I do it all the time when I'm at school and I'm a Michigan fan and people come in with Ohio State and I'm just like, well, I don't think I want to hire you, but I'll get over it. But I use that example, and I use that example in Cleveland because, right, we can chuckle about that, but it begins to make us think about things that we do, things that we say, and how do we train ourselves not to fall into that trap. One way I train myself is sometimes I don't watch the news. I just kind of read the things that I want to because I want to shield myself from that. So I agree, but it's a never-ending cycle. If we buy the paper, then they're going to keep doing it, right? If we stop looking at it, if we stop supporting it, if we offer our own views, right, collectively, then will that change it, okay? So that's my answer. Yes?
I love what you're saying about seeing the person as an individual, as a whole. I'm a little bit confused about this cultural competency piece, and inclusion is I know the NCCJ program, and I think that's great, but all of these programs are created not as ends in and of themselves, but as a beginning. At least that's what I've always thought. And I wonder what your thoughts were as to how we get to a place where we recognize, wow, I do see this, and I am looking at this group and generalizing and stereotyping.
How do we get there? To me, in terms of, personally, I would change cultural competence because I don't think it's cultural competence. I don't think the problem in our healthcare system is cultural competence. The problem is how we view healthcare and what the end goal is, right? And so, as you said, what is the end goal of our healthcare system? Is the end goal to treat the person, to make the person better? What is the end goal? When a person comes in and they are not helpful, I'll just give you a story. Like my grandma goes in, she's 91. As soon as she's in there, they see her, she's 91, they're not listening, right? And so, but that's because is our system to listen and do the best for our patient, or is the system to treat that thing and get them out? I don't know. Because I'm not a healthcare provider. I can only tell you what I see from outside the system, and I don't necessarily know that it's always to listen to get me to a better health, which may be just listening and saying, you know what, I have no idea. Go write it down. We'll work together to get this goal. To me, that's more important than cultural competency because it treats me as a human being. I don't really need my doctor to understand my culture, but that's me, right? What I need you to do is listen to me as the person that I am. Another person may need you to understand that I'm not going to make a decision without my family because that's who I am. That could be Latino, that could be African American, that could be white. So to me, it's more about empowering, like the first speaker said, right? You have a patient and your goal is to really help that patient. That's what I want, is a change in our healthcare system. So cultural competency, I would get rid of, because to me, it's more about how can we work the best to improve this person's care. Which is going to be a whole different thing, right? You fund it differently, you focus differently, your whole perception is different. So that's me. How do we get there? Incremental steps with inclusion, with a home health care home, with different things. Yes?
Thank you for a fabulous discussion. I mean, just what we have seen here, I think is an example of what we're wanting to talk about. I'm a physician. I'm an academic physician, and I agree with you that it's not about cultural competency, it's about what cultural competency is a part of, and it's a culture of inclusion, which is what we've been saying. I would also say it's not just about physicians.
Oh, right.
It's about everybody on the healthcare team, because these same presuppositions and biases exist throughout. And I guess I would make two observations. One is, I think that the culture of any system is reflected in the kinds of people that populate that system. It's what they look like, it's how inclusive they are amongst each other, it's how they recruit themselves to those processes, and how they reflect their behavior within that context. In the educational system, there's a lot of discussion about what are we doing to teach our students, our residents, our fellows, our young faculty, to become more inclusive in their attitudes. And my observation has been, and my experience has been, that it relates to the mentoring that we do at every level. It's how we incorporate, it's how we recruit, it's who we bring into the process to teach, and then it's how we teach them. When I walk into a room with a group of residents or fellows or students, and I talk to a patient, every one of them is watching how I do it. And they take away from that singular experience, and they build on that, and then they use the same words, they use the same attitudes, and the same way of touching patients. We are not doing a good job in faculty development. We're not doing a good job in an inclusive environment in terms of how the kinds of students that we're bringing into our medical schools and the kinds of faculty that we're trying to develop. That's the action point. That's where we need to go, and that's what's not being emphasized right now.
And so let me talk about that. Yes, inclusion. What's interesting, I'm going to stop after this because I was told I'm done out of time. So, yes, inclusion is important. And much of the focus on bias, right, in the Institute of Medicine report focused on physicians. There's some information about nurses and some of the fields, but we're not talking about everybody being involved. And so I definitely agree with you about at the medical school, but as was said before, right, how do we get that training? Right? How do we get people to be different in the medical school faculty? How do we begin to do something that is uncomfortable, which is bringing people in who we feel are not like us, but who can be if we just take a moment and believe or think or see them differently, right? That we always want to bring in people close to us, mentor us, who are like us. But what I would say to you is if you get the time to know the people, they may be more like you than you think, right? And that's the whole thing about inclusion. We're all human, so we're all alike. And that's why I try to get rid of the race or the things that are different about us, even though they are, but we should include people. So I'll stop with that, and thank you so much.